Everyone. Good afternoon, everyone, and welcome to today's webinar. We are going to touch on management of endometrial cancer. My name is Dr. Vincent Onyengo, not Onyengo. Onyengo means to shake, Onyengo means to take off. Maybe just for purpose of clarity on that name.
Apologies for that. Sorry.
No worries, on a light note. So the reason why we chose endometrial cancer management is because endometrial cancer is one of the most informally managed gynecological malignancy. And because of that, we thought if we can come through it, we'll be able to narrow down the differences and maybe come to a more closer common ground on managing endometrial cancer. So our presenter today is none other than Dr. Arnold Buga. He has an MB CHB from University of Nairobi, MD also from University of Nairobi in Obsgyn. He has a postgraduate diploma in sexual and reproductive medicine from University of South Wales. Currently, is a first-year Gynaecological fellow at the University of Nairobi, and his mantra is to revolutionize gynaecological malignancy management in Kenya. He also has an active private practice at Magharibi Health Specialist that is located at Fortis building. Dr. Buga, the floor is yours.
Thank you, Dr. Onyengo, for the nice introduction. My name is Dr. Buga Arnold. So, uterine cancer is ranked as the second most common gynecological cancer in high-income countries, and the third most common gynecological cancer in sub-Saharan Africa. According to GlobalCan in 2022, Kenya reported an estimated 829 cases, which accounts for 1.9% of all diagnosed cancers. That was there in Kenya, with a mortality of 257. Over 90% of these cancers originate from the endometrium, the rest coming from the mesenchyme, that is the myometrial smooth muscle, and the endometrial stroma. It usually peaks around 60 to 70 years, but there's a notable 2 to 5% that are diagnosed early, below the age of 40. So traditionally, endometrial carcinoma has been classified for years by their histomorphological, metabolic, pathologic, and also prognostic features. Them being divided to type 1, which is the most common, non-aggressive type, and type 2, the least common aggressive type. So type 1 encompasses the low-grade endometrial carcinomas, usually around 80% of all endometrial carcinomas. They're usually estrogen-driven and usually associated with women who are obese. They're usually preceded by atypical endometrial hyperplasia, occurring at an earlier stage, and are usually estrogen and progesterone receptor positive. They do carry a favorable prognosis with an 85% 5-year survival rate. Type 2, the aggressive type, are usually the other non-endometrial histologies, serous clear cell mixed and differentiated and carcinosarcomas, and also including the grade 3 endometrial histology. So those are classified as the type 2 aggressive ones. They are less common than the type 1 and typically not estrogen-driven and usually occur on an atrophic endometrium. Since they are a bit different, some of the risk factors include a lower body mass index, tend to be more on the black race, older age, and also in women who had a previous history of breast cancer. They carry a very unfavorable prognosis as compared to the type 1. However, this classification has changed over time, as we'll see later, to incorporate the molecular profile features. This has helped to provide more objective and reproducible categorization that may inform in prognosis and treatment. We'll come to that a bit later. So talking about some of the risk factors, these risk factors are mainly the type 1 risk factors, since those are the most common one. Unopposed estrogen plays a major factor, be it from the exogenous side or the endogenous side. So from the exogenous side, these postmenopausal women who are using hormonal replacement therapy have a significant increase in getting endometrial cancer after 1 year usage of unopposed estrogen, be it moderate to high dose therapy from any route of usage, be it oral, transdermal, vaginal ring. So unopposed usage in this therapy increases the risk. Tamoxifen usage, which is usually used in early stage breast cancer and recurrent breast cancer disease treatment. It's a selective estrogen receptor modulator, being a partial estrogen agonist in the postmenopausal women. It's also associated with endometrial carcinoma. Going a bit to the endogenous type, the endogenous chronic anovulation in cases of PCOS because of the persistent estrogen availability is also associated with endometrial carcinoma. Obesity, because of the aromatization of androgens to estrogen, and also they tend to have a low sex hormone binding globulin, increasing the activity of the steroid hormone. It makes them also a bit susceptible to endometrial carcinoma. Others which we have seen, estrogen secreting tumors, the granulosa cell tumors has also been associated. Some literature talk about 5 to 10% of women who have granulosa cell tumor susceptible to endometrial carcinoma. Early menarche, late menopause, others which are risk factors to endometrial carcinoma. So when we go a bit to the hereditary risk factors, the most common one is the Lynch syndrome, formerly known as the HNPCC. This is an autosomal dominant disorder. It's a disorder that is caused by germline mutations, or one of the several DNA mismatch repair genes. We'll mention it in a few seconds. But it accounts for 2 to 5% of all women with endometrial carcinoma. The lifetime risk being around 13 to 71%, depending on the genotype in which is mutated. If you compare this with the general population, the lifetime risk is around 2.7%. Cowden syndrome, also an autosomal dominant disorder with mutation of the P10 tumor suppressor gene. The risk of developing endometrial cancer when you have this is around 13 to 19%. First-degree relatives with endometrial carcinoma, the risk is around 3.1% by the age of 70. General population is usually less than 2%. BRCA association, it's still unclear, but some literature talk about association in BRCA1. So some of the genotypes in terms of Lynch syndrome association, if you can see there, MSH2, the genotypes actually associated with MLH1, MSH2, MSH6, PMS2, and EPCAM. But the one that has a high risk is the MSH2, around 21 to 71%, then the MSH6, 17 to 71%, PMS2 being on the lower side of 13 to 15%. Other cancer sites associated with Lynch syndrome, as you can see, is colorectal, gastric, ovarian, bladder, prostate, and breast. So as I'd mentioned earlier, the type 1, type 2, sometimes called the Bachmann classification, has evolved over time to integrate the current molecular profile features. As I said earlier, this enables to provide more consistent predictive treatment and prognostic information. It is not yet fully integrated into clinical practice, but with time and current clinical trials that are ongoing, it will be. So this was brought about by the Cancer Genome Atlas of 2013, where they used the genomic, transcriptomic, and proteomic analysis to characterize more than 370 endometrial cancers and ended up identifying 4 molecular subtypes based on the architecture, prognostic outcomes, and the clinical pathological features. This was thought to be more producible, and as I said, it provides a more prognostic value, especially in response to treatment, be it radiotherapy, chemotherapy, or targeted treatment. And it's better because its assessment just from the normal endometrial biopsies and curating. So the 4 major molecular subtypes are the ultra-mutated DNA polymerase epsilon. We'll talk about them in detail a bit later. The hypermutated microsatellite unstable group, or the mismatch repair deficient group. Copy number low group, which is also known as the P53 wild type, or and the copy number high serous-like group, also known as the P53 abnormal type. So just to pass through them in detail. So the Pol ultra mutated is thought to be in about 7 to 9% of all endometrial carcinomas. And some of the molecular features, it's known to have a markedly high tumor mutational burden. And pathological features, the features of lymphovascular space invasion, aggressive features. Of note is they tend to have prominent tumor-infiltrative lymphocytes. From the TGA, it was noted that the Pol mutations were more on the endometrial grade 3, 2, 1 in that order. And some of the clinical features of those women, they were younger women, thinner. But despite having these aggressive pathological features, it was shown that they were highly favorable prognosis with a high 5-year survival rate, more than 96%. With this in mind, the escalating of adjuvant treatment is being entertained. Some clinical trials are still ongoing to incorporate that into clinical practice. Having a high mutational burden and prominent tumor-infiltrating lymphocytes makes them susceptible to checkpoint inhibitors in the rare cases of advanced and recurrent tumors. The microsatellite, the MMR deficient, occurs in 26 to 30%, still has a high tumor burden, and the mutations were noted to be similar to the ones that occur in the Lynch syndrome. The pathological features are still aggressive, but the prognosis is intermediate, and they are a bit susceptible to radiation therapy. Again, with the TIL being high and the tumor mutational burden being high, checkpoint inhibitors tend to be favorable. The copy number low, or the P53 wild type, was the most common one. 45 to 50% of all endometrial cancers with a low tumor burden. They have a squamous differentiation, and they mostly occur in the low-grade endometrial carcinomas. Often occurs in younger individuals who have high BMI. Of note, also in the molecular features, they were estrogen and progesterone receptor positive, making them susceptible to hormonal therapy. Their prognosis outcome tend to be intermediate to favorable. The aggressive type P53 abnormal occurs in around 13 to 18% of all endometrial cancers, has a low tumor mutational burden. Aggressive features on pathology, very poor prognostic features with approximately 50% 5-year survival rate. And around 20 to 25% are thought to have overexpression of HER, HER2, the human epidermal growth factor 2. And it's thought that those HER2 targeted therapy can be used in these patients. So in the clinical presentation, majority of these postmenopausal women tend to present with abdominal uterine bleeding. This occurs in 75 to 90% of the cases, but it's less common when you go premenopausal and the lower ages, occurring around 5% of the cases between 35 to 45, and around 17% of the time of the women who have endometrial cancers in the ages of 45 to 54. Though not diagnostic, the abnormal cervical cytology can give a high index of suspicion during pap smears, especially in women over 40 years with features of atypical glandular cells of adenocarcinoma. And it is shown that the sensitivity of a conventional pap smear can, for endometrial cancer is around 40 to 55%, being a bit higher on the liquid-based, around 60 to 65%. Sometimes on the incident, this suspicion can be raised during investigations of benign issues of the uterus, where one does imaging. And endometrial thickness is one of the areas that is usually looked at. Typically, postmenopausal women tend to have the endometrial thickness less than 4 millimeters, actually averaging around 2.7 millimeters in the postmenopausal. And those symptomatic women, this is having vaginal bleeding, who have endometrium more than 4 millimeters, tend to have a risk of around 7%. And if the endometrium is less than 4 millimeters, the risk is a bit lower, about 0.07. Unfortunately, this method is a bit less predictive for endometrial carcinoma in asymptomatic patients. So the same risk of 7% can be seen in endometrium, which is a bit thick, around 11 millimeters. And a thickness of less than 11 millimeters, the risk is about 0.002. Patients who use tamoxifen still have the same cutoff, but in essence, all postmenopausal women with the endometrial thickness more than 4 millimeters should be sampled. So how do we sample them? There are various ways they're going to do. You can do the office-based using a pipelle. It's quite simple to do and does not require anesthesia, and this has a very high sensitivity, around 90%. Dilatation and curettage, which has been considered as the gold standard for a bit of a long time, can also be used when you have a bit of difficulty with the pipelle in terms of situations of cervical stenosis, patients' anxiety and pain, or you are having insufficient sample with the pipelle. Diagnostic hysteroscopy on focal lesions can also be utilized, as it is known that DNC alone, approximately 60% of the curettage specimen samples less than half of the uterine cavity. So there's a higher risk of missing the lesion. So diagnosis hysteroscopy can be used at that particular point. So how do we stage? Endometrial carcinoma is surgically staged. This is by doing the total abdominal hysterectomy, bilateral salpingoophorectomy, and lymphadenectomy, which we are going to talk about because it's a bit not controversial. Staging procedures such as omentectomy should be done in the high-risk cases of serous and differentiated and carcinosarcomas. This is due to their high risk of microscopic omental metastases. Pelvic washing and peritoneal washing which was done earlier. Usually these days it's not done and it's not included in the current staging, but its presence of metastasis on the peritoneum is the indicator of poor prognosis. So this is the current figure classification, where if you go through it, you will see how they've staged the aggressive histological type and the non-aggressive histological type, especially in the early disease, a bit differently. For example, the stage 1, the stage 1C is the aggressive histological type limited to the polyp or confined to the endometrium. This is a bit different from the classification of figure 2009, which was the previous one. So what happens in these women who have extension to endometrial carcinoma extension to the cervix? Are they staged the same? So radical hysterectomy can be performed. You can still do the extrafascial hysterectomy with postoperative radiation, depending on the bulkiness of the extension. Primary radiation therapy, if it's too bulky, then eventually doing the extrafascial hysterectomy. Radical hysterectomy is a bit controversial because it's doing radical hysterectomy does not increase or does not improve overall survival in these patients who have extension to the cervix. So it's being abandoned slowly. And obviously, cytoreduction of any visible metastasis should be removed. So lymph node evaluation, it's still debatable on its use, especially in the absence of any grossly metastatic disease. So several options are there. There are institutions that don't do any lymph node dissection, but this leaves the patient unstaged. They are those who do selective lymph node dissection only if the risk of lymph node metastasis is present. There are various criteria to do that. So one of them is the Mayo criteria, where if you have a tumor size less than 2 centimeters, tumors which are grade 1 or 2, or tumors which are not deeply into the myometrium, they consider that the risk of lymph node metastasis to be very low, pelvic lymph node metastasis to be very low, less than 5%. So if you have these features, you might not want to do the lymph node dissection, but if you have features that are suggestive of high risk of metastasis, you end up doing the lymph node dissection. Lymphatic mapping and sentinel node dissection, it is what is currently encouraged, but its availability is still wanting. Complete lymph node dissection of all patients is also entertained, but one has to keep in mind the morbidity after that. It is key to note that lymph node dissection is only used for staging, but does not improve overall survival. This staging will direct on which type of adjuvant therapy that will be used. However, this is not so with carcinosarcoma, where it is known that lymph node dissection improves overall survival over time, and it is encouraged that all patients who have carcinosarcoma should undergo lymph node dissection. So what kinds of adjuvant therapy do we tend to give? So adjuvant therapy for endometrial carcinoma, we have to, all patients who have undergone surgery should undergo risk stratification, which again, it will guide on the adjuvant therapy. And if the molecular profiling is there, it should also be included for this risk stratification. So it is divided into low risk, intermediate risk, and high risk. The intermediate risk is further divided into low intermediate risk and high intermediate risks. So which are these low risk endometrial carcinoma? These are the grade 1 or 2 endometrioid, which are limited to the endometrium or invading less than 50% with no lymph LVSI. These patients tend to have a very low recurrence, vaginal recurrence or pelvic recurrence, less than 5%. And the likelihood of benefiting from any adjuvant treatment is very small. So in essence, we do not usually give these patients any form of adjuvant therapy as it's of no benefit. So the intermediate risk, these are the endometrioids, grade 1 or 2, with more than 50% myometrial involvement, cervical stromal invasion, and with LVSI, that is positive substantial LVSI. Also, it also includes endometrioid grade 3, less than 50% myometrial invasion. As mentioned earlier, they are divided into low intermediate risk and high intermediate risk. There are various criteria to divide that. One of them is the GOG criteria, in which they use age and risk factors such as deep myometrial involvement. This is more than 50%, the grading 1 and 2, and LVSI. So a 70-year-old with one of these risk factor is considered to be having high intermediate risk. 50 to 69 with 2 risk factors is considered, and more than 18 years with all 3 risk factors will be considered as having high intermediate risk. So how do you go about this? There are various studies that have been done from the GOG 99 early on in the 80s, POTEC 1, and eventually one that changed the practice, POTEC 2. With the GOG 99, the eligibility criteria were the stage 1 and stage 2. They are comparing either pelvic radiotherapy with no adjuvant treatment. And in this study, there were 392 eligible patients. The definition of high intermediate risk who are included were the moderately to poorly differentiated tumors, presence of LVSI, and outer third myometrial invasion. And obviously they use the age as being 50 years greater than 2 risk factors, being 70 years with only 1 risk factor. The outcomes of this were the local outcomes of this at 48 months with the low intermediate risk, the local recurrence rate and the distance recurrence rate was similar for the low intermediate risk, and also similar in overall survival. So as I'd mentioned before, there was no need for providing adjuvant therapy in the low intermediate risk. So in the high intermediate risk, the outcomes ended up being there was significant improvement in the local recurrence rate and distance recurrence rate in the high intermediate risk, but the overall survival was similar between the 2 arms. So for women with high intermediate risk, this adjuvant radiotherapy following surgery was noted to reduce the risk of pelvic and vaginal recurrence, although it does not improve the overall survival. This was similar to another similar study. POTEC 1, the only difference between GOG and this POTEC 1 was that in GOG, lymph node dissection was done. POTEC 1, no lymph node dissection was done. And with POTEC 1, the determinants were the local regional recurrence, death, treatment-related morbidity, and survival. That's how they their criteria for high intermediate risk was grade 1 with deep myometrial involvement, grade 2 with any invasion, grade 3 with superficial invasion. The outcome at 5 years, the local regional recurrence was better in the radiotherapy group, 14 to 4%. And again, similar with the GOG, 99. Overall survival was similar. Of note, toxicity related with the radiotherapy was quite high at around 25%. But all in all, it was noted that adjuvant radiotherapy in stage 1 endometrial disease reduced local regional recurrence, but had no impact in the overall survival eventually. So with the high toxicity levels noted in the POTEC 1, another study in the early 2000s was done called the POTEC 2, which was comparing vaginal brachytherapy versus external beam brachytherapy for patients with endometrial cancer with high intermediate risk. Here, the eligible women were 427. Between the two arms of ERBT and VBT, local regional recurrence and distant metastasis was similar, but the toxicity level was quite low in VBT as compared to the ERBT. So at this point, this changed practice in terms of management for the high intermediate risk, and vaginal brachytherapy was instituted as the mainstay of treatment for high intermediate risk endometrial carcinoma. So on high risk, these are the non-endometrial group, which are the serous adenocarcinoma of any stage, clear cell adenocarcinoma of any stage, grade 3 endometrial, more than 50%, and stage 3 or 4 of any histology. This is so because of the high intra-abdominal distant spread metastasis with poor prognosis. In essence, there's no clear approach to adjuvant treatment, but what is known is staging of the disease is usually considered. Women who have stage 1 and 2 disease tend to be offered radiotherapy, VBT, advanced myometrial disease, stage 3 and above tend to be offered chemoradiotherapy, as you're going to see in the couple of studies that were done. So there are several that compared adjuvant radiotherapy and chemotherapy in endometrial cancer. But the three most important ones were the POTEC 3, GOG 249 and 248. POTEC 3, which was done early in the 2000s, they were comparing this. The eligibility was stage 1 to 2 high risk factors and stage 3. They were using the pelvic radiotherapy in one arm versus the pelvic radiotherapy that is sandwiched with the chemotherapy of cisplatin, 50 milligrams per meter square, followed by carbotaxol of 4 cycles. In this study, the 5-year survival rate, there was not much different in stage 1 and 2 between both arms, But from stage 3 and serous endometrial carcinoma, there was significant improvement in the overall survival. In GOG 249, it had a similar setting. They were comparing adjuvant pelvic radiation therapy versus vaginal brachytherapy plus carbotaxel in high intermediate group and high risk early stage endometrial cancer. In one arm, they were giving the VBT with the carbotaxel, and in the other arm were giving ERBT 45 to 50 in 1.8 to 2 fraction. So both arms were comparable, but acute toxicity on the vaginal brachytherapy and chemotherapy was shown to be present in the acute stages, but in the late stages they are a bit similar in both arms. Pelvic recurrences were noted to be more in the VBT and carbotaxel group as compared to the pelvic radiotherapy group. And in this, they noted pelvic radiotherapy alone remains as effective and well tolerated, and appropriate adjuvant treatment in high-risk early-stage endometrial carcinoma of all histologies. So in this, I think I'd mentioned in the POTEC 3, in which they were using one arm radiotherapy alone, and in the second arm, radiotherapy and chemotherapy consisting of 2 cycles of cisplatin, sandwiched in the radiotherapy, and then followed by 4 cycles of carboplatin and paclitaxel. It was only significant in the higher stage 3 and 4, and also the serous. And as mentioned earlier, chemoradiotherapy was left to higher stage groups, stage 3 and above, in terms of management of endometrial carcinoma. So in terms of timing on how you're giving this pelvic radiation with chemotherapy, again, it's not so clear, and each institution are forming their own protocols. Many centers prefer the sequential treatment, chemotherapy, then radiotherapy, or radiotherapy, then chemotherapy. Sandwich therapy is also being utilized, depending on how the patient is. So in essence, you have to individualize these patients, basing them on risk assessment, toxicity, and also what your local context is doing. I'll mention a bit on these women who desire fertility, and is there a space for fertility sparing in selected patients. So the selection criteria, these women should be in the reproductive age group, and they desire to conceive, but there's a very strict criteria to this. There's candidates should have all these characteristics before they should consider fertility sparing. They should be grade 1 only endometrioid, and this has to be confirmed via DNC. The tumor should be confined to the endometrium only, being confirmed by the MRI and pelvic sounds. They should have no contraindications to hormonal therapy, as we are going to use progestins. And of key, they should understand that this is not a standard care, and the risk of understaging clinically is high, whereby you might be putting someone as the tumor being confined only on the endometrium, whereas if they are surgically, they're actually advanced stages. So there's a risk for that. And We usually put these patients on the progestin therapy until completion of childbearing. Then you have to do the surgery. And they should know the efficacy of this compared to surgery is quite poor and has a higher mortality. So thank you. That was a short presentation on the management of endometrial carcinoma. So thank you.
Thank you, Dr. Buga, for the excellent, comprehensive presentation. I can confidently say you have captured most of the salient features. Maybe to break it down and to our audience, the take-home message is that, first of all, cancer of the endometrium, basic investigation that should be done is an endometrial biopsy. And the purpose of that endometrial biopsy is to guide you to know the type of the surgical type you are dealing with. Is it type 1 or type 2? And if it's type 1, it should be graded. And the purpose of grading is to know if it's high risk or help you, do you need to do lymphodissection or not? Because all type 2 you have to do lymphodissection and mastectomy. But type 1, the ones which meet my criteria, can evade lymphodissection. So endometrial biopsy is key. And if it's type 1, grading is key. Secondly, imaging is key. One, to tell you the extent of the disease. Is it the tumor size more than 2 centimeters? Is there a myometrial invasion more than 50%? Also equally to guide you on the extent of the surgery you will do. Will you do lymphodissection or not? And lastly, also the issue of adjuvant treatment. You have seen that most of the studies were either giving VBT, that is vaginal brachytherapy, and chemotherapy, or pelvic radiotherapy alone, apart from PROTECT-3 rather, sorry. PROTECT-3, which did combined EBRT and 2 cycles with cisplatin, and after that gave 4 cycles of carbotaxol. So there's no role of combining, doing carbotaxol 6 cycles, doing EBRT, and doing VBT. That toxicity will be too much for the patient. It's either you do VBT with 6 cycles of carbotaxol, or do pelvic radiation alone, or if you are going to do PROTECT-3, which was EBRT with 2 cycles of cisplatin, and after that giving 4 cycles of carbotaxol, it was only overall survival was seen in patients with endometrium stage 3. And also in some patients, they gave VBT in that for PROTECT-3, but the ones which had vaginal margins were positive. I think apart from that, the rest of the issues were very clear and well elaborated. Thank you, Dr. Buga, once again. And maybe you can open now the forum for comments, input from the audience. If there's no comment, maybe we can go to the questions. Question number 1, is there no risk of cancer dissemination with the ethoscopic biopsies? Dr.
Okay.
Buga, you want to take on that?
Yes. Okay. I don't think there's any evidence of preoperative hysteroscopy worsening the prognosis of this. There's a slight risk for dissemination because of the fluid that is the water-based fluid that is used during endometrial cavity distension, but it may not worsen the prognosis of these patients, especially stage cancer.
Exactly, and mainly as from Dr. Buga's presentation is that PIPEL, the office procedure, is equally sensitive and specific. And before you reach hysteroscopy, you have to do a DNC. And actually, the superiority of DNC over PIPEL is in terms of grading. But in terms of the other sensitivity and specificity is the same. And hysteroscopy, we usually use it when we have mainly negative endometrial biopsy and there are high index of suspicion of malignancy. So we rarely use it, but we do. So it's like the last option. But again, as rightly put it, the chances of disposition are very rare by then. So actually, they're confined within the uterus, the procedure, the surgical procedure you are doing. So the other question is, what is the applicability of the FIGO 2023 updating staging system in our setup? Is it too much, too soon? Dr. Buga, you want to take that one?
I don't think it's too much too soon, because if you see the figure 2023, if you look at POTEC 2, the 10-year review, where they looked at these patients who had aggressive based on the molecular analysis and based on the molecular analysis and the vaginal recurrences. It picks out how we can easily miss out high aggressive cancers if you're using the figure 2009 as compared to the 2023 one. Case in point is figure stage 1C, which is confined to the endometrium, but an aggressive histology. This will be regarded as high risk in let's say in a situation where you have a type 2, the carcinosarcoma or clear cell. But if you look at the figure 2029, it will have been regarded as a low risk, and the vaginal recurrences are quite high. I don't know if I've answered that.
Yeah, and equally, of course, there's an issue of cost implication. Like one marker at Lancet costs around 30 to 40K. If you are to do all the 4 subtypes, that will go around to 120, which is not loose cheap for average population of Kenya. But the way the other countries are looking at it is the cumulative cost. If you are subject a patient to go for 6 cycles of chemotherapy and 3 or 2 cycles of VPT or 25 sessions of pelvic radiation, which is cheaper? And of course, not also factoring in the toxicity associated with this adjuvant treatment. So that's why the people are looking at the molecular classification as a superior and less toxic way and more accurate way of predicting prognosis. So if we can afford, if a patient can afford, the better. And maybe also with time, because it's a new thing in the market, maybe the prices will drop down, hopefully. But if you weigh between the two cumulatively, the molecular classification is much, much cheaper and less toxic and more accurate in prognostication. Another question is, the issue of, do you want to comment about the issue of momentectomy in C endometrium? When do you apply? I think I mentioned about it, but maybe Dr. Buga, you can repeat. Which types do we do a momentectomy and why? Maybe for the audience.
So momentectomy, it's advised to do it on the serous, as they do behave like the ovarian, the microscopic omental metastasis, and also in the undifferentiated clear cell. They have a high risk of having microscopic omental metastasis, and this will reduce the pelvic recurrences, pelvic and abdominal recurrences.
Thank you. And can you comment about how to differentiate between cervical primary from endometrial primary, especially for stage 2 for endometrium where there's cervical involvement? Many times there's a confusion among our colleagues if it's primary cervix or primary endometrium.
I think with primary cervix, primary endometrium will tend to have the glandular differentiation, adenocarcinoma. With the cervical, you'll tend to have the squamous cell picture. I think that's what they were asking.
Yeah, and of course for endometrium, we'll have serous. If you see a cervical biopsy giving a histological diagnosis, then chances are that is primary endometrium. We rarely have serous of the cervix, but majority of the histological subtypes of cervix, of course, is squamous cell carcinoma, almost 70% or 25%, followed by 20 to 25% of adenocarcinoma, and of course, adenosquamous around 5%, and of course, the rare one, the neuroendocrine. So actually, the histology will guide you to know if it's primary, ovarian, or endometrium for the cervical mass. I can't see any other question unless I've left it. Maybe the comment on quality sparing management for endometrium type 1.
The what? I didn't
You
get
mentioned
it.
about it, the criteria.
The criteria for fertility sparing.
For using conservative management, progesterone.
Of fertility sparing, there's a very strict criteria. It has to be grade 1 endometrioid. It has to be confirmed that it's just it's not invasive to the myometrium, just contained on the endometrium. And of key, you have to do counseling and make the patient understand that this is a substandard care vis-a-vis the surgical management. And it has a low 5-year survival rate and a very poor mortality. Increased mortality, sorry. That is the period of time in which you can use, where you'll give this progesterone until the end of childbearing, or when she decides that she's conceived the children that she wants, and then you have to do surgery after that.
Yeah, thank you. And I don't know if you can comment one on somebody's asking there's a role for colposcopy in diagnosis of endometrial CA. I don't think we don't have a role for that. Colposcopy is mainly a preserve for CA cervix. And another question is about commenting on negative endometrial biopsies you get in atrophied endometrium. As you said, when a woman presents with postmenopausal bleeding, your first diagnosis, or we can say, is malignancy until ruled out. So if you get two if we do our endometrial biopsy is negative for in a postmenopausal bleeding woman, you put another one is negative, you're better doing a hysteroscopy. That's one of the indications of hysteroscopy. And many times you find either it's a polyp, or as Dr. Boga said, many times our DNC and PPL are blind procedure, and 60% of the endometrium is not covered. So you may be able to see where the lesion is and get a biopsy from there. And lastly, Dr. Boga, I don't know if you want to comment about adenosarcoma and endometrial sarcomas. Another topic for another day, because it's equally broad.
It's quite broad. I think that it'll take a bit of a while, but we can schedule that for another presentation.
Yeah, I think that would be the ideal thing. Maybe you can do one for the other sarcomas. I know you mentioned about carcinosarcoma among these your presentation. The reason why you mentioned it is because carcinosarcoma is treated the same and classified the same as type 2 C endometrium, unlike the other sarcomas, which are classified and treated differently. So I think maybe from the KNH team should be able to organize a webinar for adenosarcoma and endometrial sarcoma, the other sarcomas. So the last question is there any protective benefit from Mirena against endometrial hyperplasia?
Yes, data suggests there's a bit of a protective mechanism. Mirena, combined oral contraceptives, multiparity, are equally protective.
Thank you. Any comment from the audience or clarification or input even from our colleagues? I know there's gynaecologists also or among the audience. If there's none, we'd like to thank everyone for getting time to attend today's webinar. Equally in the same breath, thank the KNH webinar team for organizing today's webinar. And it was a quite interactive session. We have learned a lot, and we are looking forward maybe for the next webinar, God willing. Thank you, everyone. May God bless you.
Thank you as well, Dr. Vincent and Dr. Buga, for the presentation. And to our audience, as mentioned, or as you can see on the poster, we have an continuing or ongoing gynecological oncology series. So be on the lookout on your emails and also on your WhatsApp and our social media pages for the next subsequent events that will be coming up. Thank you once again for joining us today. We will be back next week on Tuesday with another session, and we'll also make these communications through the normal platforms. Do have a good week.